Good morning, everybody. I am delighted to welcome you to the second of our series of digital events in taking what is a special part of what we do at Rhodes House, where we bring alumni back to speak to scholars or bring alumni and scholars together for forums on important topics. In this era of digital and virtual gatherings, we felt that it was very important to share the expertise about COVID-19 that so many of our scholars have, and to enable us to connect across national boundaries and generational boundaries. So this is the second of our series, and we're absolutely thrilled to have Devi Sridhar, who is Florida and Wolfson 2003 Rhodes Scholar. She is Professor of Global Health at the University of Edinburgh and was recently named to chair a Royal Society commission on COVID-19. She's also the author of, among several books, but her most recent book is Governing Global Health: Who Runs the World and Why? So somebody with enormous expertise who has really thrown herself wholeheartedly into the fight against COVID-19, has been, as she has said, a kind of friendly critic of the UK government and an important public intellectual, and now an advisor through her Royal Society role. So Devi, welcome. We're delighted to have you.
Well, thank you for having me, and I'm always delighted to hear from the Rhodes community and to, listen and learn as well from all the scholars who are working in Oxford and beyond. So looking forward to your questions and hearing also about what you're up to.
Wonderful, thank you. So just a couple of housekeeping points as we begin for those of you who have joined us. So this is a Zoom webinar, and that's why you are, your video function is not functional, and you've also all been muted. But what we're going to do is we'll start the conversation, have Devi introduce herself, and we have a number of questions that folks have sent in already, so we'll start with those. And then you will be able to, through the Q&A function, as well as the chat function. So you have two ways of asking questions. You can click on your screen the Q&A, and that will pull up a screen, and you can go ahead and type a question, and we'll be monitoring that during the course of the call. You can also, if you wish, on the raise your hand on Zoom, and so we will then unmute you so you can ask a live question or make a live comment. So those are the two ways in which you can raise a question and participate. Just a note that we are recording this, and we will be sharing that with this recording with the Rhodes community. So if you don't want to be on the recording, then please use that Q&A function to ask your question. So, and then at the end, I'll be sure to see if Devi has any closing remarks as well before we close off the event. So let's start, though, Devi, with you were elected as a Rhodes Scholar in 2003 from Florida, and you're now a professor of global health at the Medical School of the University of Edinburgh and heading a Royal Society commission. So tell us about that journey, your journey from Oxford to Edinburgh and your focus on global health.
Yeah, no, thank you. And I wanted to say that also these webinars, I could talk a lot of these things, but I'm going to try to give short answers so we can hopefully get your questions in, and it's not too boring for anyone watching when I'm speaking. So I was a Rhodes Scholar in Oxford, and I came having held a place for law school back in the States, and thought I would just do 1 or 2 years and then go back to law school. I did want to work in healthcare policy, but I had a very strong feeling that law was the way to do it, and that law school would be the way. And it was actually talking to someone from the Kaiser Family Foundation in the States, where I worked for a summer, who said to me, if you want to do really interesting research, a PhD would be a better track for you than a law degree, because as a lawyer, it's maybe not going to be what you're sounding like you want to do, which seems to be engaged in policy and doing research and teaching. A PhD is probably a better track for you to do that. So I deferred my law school place and decided to do a PhD at Oxford. And I went out and did fieldwork in India and tried to just get a handle on how policies made, in offices actually play out on the ground, and try to understand a bit about, development and public health on the front line, in a sense. How does it look for nurses, for health workers? So that was that. And then after I did a postdoc in Oxford, gave up my law school place. I think they got tired of me continually deferring, so I lost that. And worked with Nairi Woods, who's a professor there, who was just starting out a new program on global governance issues. And she said to me, areas around global financing of health, global development assistance, global rules. This is going to be an emerging area, and it's one you should really really dig into. And so I started at that point doing it. Ended up staying at Oxford. I was at All Souls for a fellowship for 5 years, which gave me time to kind of work on my book and really kind of get into WHO issues and health security issues. And then was a lecturer at Oxford in the Department of Public Health, associated with the Blavatnik School of Government, and then moved up to Edinburgh about 7 years ago now. And have managed to really enjoy Scotland, despite it being probably the farthest place you can get from Miami, where I grew up and went to university initially. I mean, it's so different in every way. And it's, I do sometimes wonder how life is, that you end up in places you never would expect. But I really like it here. And I've built kind of a small program called the Global Health Governance Program. And one of our strands has been a working group on global health security. And we're working with different institutions across the world, including with Georgetown, which has a large focus on this. And so I've been working on Ebola, on other outbreaks, on generally how do you prepare low-income countries and middle-income countries, because most of our expectations was that an outbreak would start in a poor environment rather than this has been almost like back to front outbreak that we've seen it emerge in rich contexts among, skiers in holiday resorts and places that you usually don't expect. Tried to be, I guess, through this, working with WHO, working with different governments, trying to be kind of a bridge between different governments and what they're doing, and trying to do policy analysis at the same time on actually best practice and how do we work in a very fast and emerging context where there's no easy answers.
Wow, that's great. That's great. Thank you. What an amazing journey. And as you know, it's always fascinating to me how scholar journeys, you don't end up where you think you're going to end up, but you've certainly ended up in a place that is so important and impactful right now. So the questions are pouring in. So I'm going to, so let me start with a question that was sent in advance that it seems that the international scientific community is collaborating a lot to address COVID-19, but the national responses have been more isolated. And what are your thoughts about that? And is there a blueprint? Are there lessons already to be learned for more cooperation in setting national policy?
Yeah, so on the scientific side, I think this is probably one of the best things that has come out of this outbreak, if we can think of anything good, has been the scientific collaboration, and actually a lot of it being open access and not much concern for who gets the credit, which is always a worry in academia, that actually what we've seen like with the Ebola outbreak, that people don't publish or share their data openly using preprints. They wait for peer review, which obviously has delays. So I think that's been really positive, and I've benefited a lot as well from my colleagues across the world, kind of constantly checking in with people in the States or Australia or even Senegal to kind of take stock, or India, take stock of what are you doing? How are you approaching this? And so I think that's been incredibly inspiring and shows that we have learned lessons from previous outbreaks, at least the scientific community, that actually speed is important, sharing is important, and actually, at least for this stage of time, we need to put aside our kind of focus on publications and grant income and all those things. I mean, those all seem like minor concerns right now. On the flip side, what's very worrying is you do have had rising tensions between two superpowers, the United States and China. And this has been over trade issues, it's been over economic issues, and the latest is coronavirus. And this creates a lot of instability, instability in the world, and it destabilizes relations. You could see this in the WHO and how, its funding has now been cut by the US government. We'll see if that decision is reversed, but that basically we're in a scramble for every country for themselves. We've seen this with ventilators. Countries are trying to acquire them themselves. They're not thinking of other parties. And so ideally, I hope there'll be some learning for this, because the next scramble is going to be over a vaccine or an antiviral, which is really our only true way through this. And if the vaccine is manufactured in China or kind of discovered in China, does that mean the Chinese population gets it first and the Chinese government decides who gets it? Which means I don't know if America is going to be top of that list or not. If an American scientist discovers it, does that go to American manufacturers? What does that mean for who gets it? And so I think this is going to be the next thing that I hope we could get plans in ahead of time. But if we learned anything, again, from previous outbreaks, whether it's limited, with Ebola, we had ZMapp, an experimental therapy that went to citizens of certain countries and not of others. It was a scramble. We're seeing this now with PPE, protective gear. So I hope that we will learn our lessons, but I'm quite cynical as well from having seen things play out. And I think the WHO has a really nightmarish role of trying to balance and keep all countries at the table while appeasing them, when a lot of blame is now also being thrown around of actually who's responsible for this virus, yes, who actually is responsible for the mounting death toll, especially as countries are now in some kind of bizarre race of competing over, cases and deaths and so on. And so obviously feel kind of under a heavy spotlight for that. So.
Yeah. And I'm sure, you have that kind of dual role. You've been actually quite critical, publicly critical of the UK government's particularly initial strategy. You were one of a number of experts who criticized that and called for much more testing and much more speedy lockdown. But of course, now you're also advising through this Royal Society. So I'm sure it's an interesting role of being a public intellectual in these times. Would love to hear you reflect on that. But I have a question here from a current scholar, Andres Noe, who's asked, test, trace, isolate seems to be one of the ways through lockdown. Does the UK have adequate testing infrastructure and sufficient tracking expertise and legal instruments to mandate isolation?
Yes. So I think, the good news is after weeks and weeks, I feel like we're finally getting consensus that this is probably one of our best ways out. And I'd say to get to that point has taken weeks, because if you think back a couple weeks ago, and even now, you will hear sometimes people saying testing is not important. So even that recognition, I have to say, has not been easy to come by. And even Nicola Sturgeon, the First Minister of Scotland, clearly saying that within Scotland's exit strategy, this is going to be a key component. Does the UK have enough testing currently? No. The WHO says that for every case, every confirmed case, and they actually mean symptomatic, but even if we take the cases which are hospitalizations in the UK, we had yesterday 5,500 roughly. So if you needed 100 times that, which is what they recommend, 100 tests per case, we would be looking at 500,000 tests a day. We are far off. And I think making the comparison, it's also interesting with comparisons and saying, well, South Korea is only testing 15,000 people a day. So if we're testing 20,000, we're doing well compared to South Korea. Misses the fact that it's not how much you test, but when you test. So if you test when you have a lot of cases, you have to test obviously more people because it's spread around, where if you have less cases, you test less people. So that is a major challenge. And I think right now there is this kind of scramble to try to increase that, but it's not only getting the labs built, it's actually getting it out to people. So we need drive-through solutions, we need walk-through solutions, contact tracing as well. I think the expertise is there. A lot of other countries like Singapore have been following UK guidelines on contact tracing. I think we don't have the manpower in terms of we don't have enough people. It requires thousands and thousands of people. So there needs to be, thought given. And I think it is going on about how do you recruit that many people? And also how do you use apps? So completely right, Andres, about the legal instruments, because South Korea, after its MERS outbreak, one of the first things it did was not only diagnostic capacity, in terms of reflecting on it, but also the legal changes to be able to get people's credit card details, mobile phone details. So they preempted this, right, by getting all this and not having to worry about it later. And this will have to be a debate here, because we will need, a significant part of the population to use these apps and to actually disclose where they've been for the past week in terms of their movements, who they've been in touch with, as well as, and this is what will also have to be in quarantine, like being monitored if you're actually at home through actually probably a location signal on your phone and actually being called or having checks to make sure you're actually there. So I don't know, would I have thought this was possible, 6 months ago? I would have said, with all the work around, data protection and, the move away from this kind of information sharing to privacy, I would have said it would be difficult. But now the choices for people are either we're all in lockdown, and all of our movements are constrained, and you can't sit in the park, you can't just be walking down the street without it being part of your exercise. I mean, we're in quite a different time right now. So I think if it's done with the right regulatory safeguards, then this might have to be, unfortunately, the least worst way forward, if that makes sense. It's not ideal, but it's the only way to kind of move forward.
Yeah, and we're already seeing some authoritarian governments using this as an excuse to crack down, but at the same time, as you say, it's so critical to be able to have the legal framework to respond in a way that saves lives. So there's a question that's come in from a number of scholars from different generations. So we have from Muzaffar Qureshi, who's Pakistan and Balliol 1958, and also from Alyssa Fitzpatrick, South Australian model in 2013. So Muzaffar and Alyssa both want to know, how do we protect vulnerable or persecuted communities under lockdown conditions? What are some of the best ways in which we can, at the policy level and at the individual level, make a difference?
Yeah, and I think that's a really important question, because I think lockdown is a very crude and costly policy instrument. It's kind of a last resort when nothing else works. So you basically shut people in their homes so they don't, and it's great if you have a huge estate or you're out somewhere remote and you can, take the time and be fine, but it really is a struggle if you're in, an abusive household, or if you are struggling for food, or if you're in other way vulnerable. And this is true whether you're in the UK, the US, or in, a developing country. It's universal. So I think some of the policy measures I've seen is actually, they're not great, to be honest, but like support hotlines, actually giving allowances for where people can go if they need support, and making that widely available through social media campaigns, just a wide awareness that actually what one person thinks of as lockdown can be a completely different experience to another. And I guess the other thing is, I agree with the decision in terms of going into physical distancing at the moment that we were in this outbreak, because it was spinning out of control. But I do wonder whether we're costing well enough the economic and social costs. And so if scholars are looking for an area to go and do research in or to write about, it's actually quantifying the social costs to vulnerable communities. So what does it actually mean for a child to be out of school? And I know it sounds crazy, but like putting a number on it, because the models all reflect cost and benefits. And basically it's very easy to put into a number disease spread, right? And it's very easy to quantify lives lost, right? Because you have a death. How do you quantify, domestic abuse in a way that can be input into a cost benefit calculation? So I think one thing is actually just bringing the evidence forward for policymakers to make better decisions. I do wonder in poor contexts, thinking of my fieldwork in India, whether more people will die of lockdown itself than of COVID. And I do think the other thing I would love to see more kind of work on is, we're often hearing economy versus health, but actually the economy is health, because, a recession is going to hurt people's health very directly. Mental health is not insignificant either. If we see a rise in suicides, or we see a rise in terms of, deaths linked to malnutrition. And so I think bringing that evidence forward, because right now we have very clear, epi models that show deaths, but we don't have good modeling around the economic or the social aspects. And in terms of individually, I think it's just getting involved with local causes from wherever you're from, or even in England, if you're based there, or wherever in the world, and looking at local food banks, looking at actually where is their need and where you can go support, because there are a lot of people struggling, and you can make a difference just by going by and offering help, or offering food, or helping set up supply chains. So I think just kind of the volunteer spirit at the individual level, but at the policy level, I think there's an absence of good information right now about this process.
Great, thank you. No, and I know we're going to be pushing out more information about what scholars around the world are doing. And as you said, Devi, there's quite a number of scholars who are setting up these sorts of local networks or getting involved in them, which is super important. We have a number of people who have raised their hands, and so we want to give them a chance to ask a question live. And the first is Frederica Reuter. And Georgie, if you can unmute Frederica, that would be great. Let's see, maybe I need to do that.
Hi, I think I'm unmuted now.
Oh, okay, excellent. Welcome, Fred.
Yes. Hi. Thank you so much for unmuting me. I think there might have been a mistake because I don't think I actually raised my hand.
Oh, okay.
Or maybe I might have pushed the wrong button, so I will hand on to the next person.
Okay, thank you. Well, I have here Kamal Wood. Kamal, would you like to ask a question?
Hello, yes, I would. Can you hear me?
Yes.
Okay, thank you. Professor Sridhar, there seems to be disagreement between experts on what's required to contain COVID-19. On the one hand, like what I'm saying here is based on my observations on TV and Twitter and so on. We have public health experts like you who think that we can contain it without strong social distancing measures. And on the other, we have pandemic modelers like Adam Kucharski of London School of Hygiene and Tropical Medicine, I think, who seem to think that we need strong social distancing measures to contain it. Assuming that that is an accurate characterization of what's happening, why do you think this difference in perspective exists? And what implications are there for policy if we turn out to be wrong about this?
Yeah, that's a great question. And that gets, I guess, to a key point over how do you actually understand and study this virus? So I think the modelers and pandemic modelers have based a lot of their training and their models off flu. And flu is basically seen as unstoppable, right? And it flows through, and that actually you pretty much can't do anything about it, which I think explains early on why we saw, the UK government move quite quickly through the contain phase. It was never really seen as being a real goal that you could contain this. This was seen, it was going to be everywhere. And so what that means is that the only way you can stop this, and it came out when they realized this was not like flu, that actually if a significant number of people would not get medical care, that you would have, tens of thousands and possibly hundreds of thousands of people dying, that actually you had to just suppress it. So the two things that were modeled for months were, suppression and basically release. And so if that's how you see the problem, then of course you think all you can do is suppress it or release it. And then you go into these cycles of lockdown, and the goal is eventually that we all get immunity to this, and we just have to control it and slow it down so that as we're all exposed to it, we all get access to medical care as we need it. And you hope that you can reach this when you get 60% of the population. I think if you look at a lot of vaccine preventable diseases, it would have to be 80 to 90%. But basically that's going to happen over 2 years, and we just go through these cycles of lockdown and release as NHS capacity seems to be strained, right? And I challenge that, as do some of my public health colleagues, because actually there is direct policy evidence that we need to treat this virus not like flu, but like MERS or SARS, other coronaviruses, which is that, yes, it's much harder to contain, but other countries have done it. New Zealand has had 16 deaths, and I think it's not far off. They'll eliminate it completely. This is because of aggressive containment and taking the idea that actually this is too dangerous to let spread. Same with South Korea. They had the experience of MERS. MERS, it has a case fatality rate of about 33%. So a third of people die who get this. SARS is 11%. So if you come from that experience of a coronavirus and you hear in January that there's a new coronavirus circulating out of China, your reaction is, this is really bad. We have to stop it. And we can do that through test, trace, isolate, and using physical distancing measures as needed to keep the numbers low. So when you feel like we've lost, and how you determine this is when you look at different clusters of infections, you say, can we link them to existing known ones? So New Zealand, and this is why, Jacinda Ardern, the Prime Minister there, said they're going to be lifting restrictions, is they can basically identify any new case to an existing cluster, which means you have a pretty good handle on who has it, which means your risk of lifting it is less. Whereas I think if you take the approach and kind of not a great position we're in the UK, that we don't know how many people have it, we are not tracking who in the community has it. I think a lot of people think they have it, which haven't had it, because everyone thinks that bug they had in January was coronavirus. It probably wasn't, given what we know now about that it's probably about 5 to 6% of the population that's been actually exposed so far. So I think this is the difference. I think the other thing that the modelers assumed was that we would have immunity to this. And what we're learning is actually out of South Korea, is it seems like either there's reinfection or there's reactivation. There's something strange going on where people are testing negative after they've been positive twice, so in a sense cured, but then they're testing positive again a few weeks later. Other coronaviruses, like for the common cold, the immunity only lasts a few months. So I think the general consensus among immunologists is that there'll be some kind of immunity, but it's not long lasting, which means what happens if you can be reinfected with this virus over and over again? Then the question becomes, and this is now being debated, when you get it again, you have milder symptoms, or will you have a worse reaction? Because you can have immune enhancement, like with dengue, where actually you get a more severe version of the disease, or it could be that actually you slowly are building up the antibodies to resist it and things get better. But I think you're asking the difference. I think this is where the real difference comes out in this, and that public health measures like test, trace, isolate are where people who work kind of frontline in outbreaks, doctors are very comfortable, where I think mathematicians and modelers are more comfortable with the code that they've written and the scenarios they outline, which are kind of macro. They're mathematicians and looking at the macro picture. Does that help answer the question, Kamal?
I just realized I had muted myself. I apologize. Kamal, so thank you for that question. I think let's, since Kamal's not doing a follow-up, I'll go ahead and ask another question. And actually it's raised by you had mentioned that you think we're probably 5 to 6% of people in the UK have been infected. We have a question from Andrew Wee, mentioning that the US president and his followers want to end the lockdown, and they've been quoting the Stanford study that shows that 2 to 5% of the population are infected, most of them asymptomatic. So the argument is it's already widespread, and it may be possible to start on a rolling basis and the lockdown. What are your views on that?
Yeah, so I think I guess it's a similar figure has been arrived at in the UK through modelers, that we're about 5% of the way through. So the question is, what do you do at this 5%? Do you say we need to get to 80% with the hope that we'll have herd immunity at some point, which means how many more cycles do we need to go through? Probably at the end of one wave, right? So we're going to go up with deaths and you go down with deaths, you'll have covered about 10%. So if you want to go to 80% and you've seen already the number of deaths, think how many more waves you're going to have to go through. And then the fear is if we're not building immunity past a few months, if it takes us a year and a half or 2 years to get through this, are we just going to start from again? So then the question is, how do you get a handle on it and actually try to bring down the number of people? And I agree that lockdowns are probably not the best way to do this in the long term, because at a certain point also people will refuse to be locked down. Compliance will be an issue. Behavioral scientists I've spoken to say once you've locked down people and you've released them, it's very hard a few months later to lock them down again, because people are going to say, no, we don't want to do this. Why should we comply? And so I think here we have to be using the time to get a handle on even like random surveillance of actually how many people have the virus. We assume it's 2 to 5%. In some areas it might be much higher. Hotspots seem to have 20%. We need to track them, follow up with them to see if they're going to get reinfection, how long immunity lasts. And at the same time, try to really contain it until we know more. I think the best position to be in is like Iceland and Faroe Islands and New Zealand, because they bring their numbers down and they can wait. So maybe we find out that there's not going to be a vaccine. then they can make decisions based on that. Maybe they find out we have a great antiviral therapy and we do have a vaccine. Then the countries which saved lives in these 6 to 9 to 12 months till we get it are going to look really smart. Maybe we figure out, actually there's nothing we can do. We all just have to get it if we want to be an interconnected world. Hopefully by that point, we actually have a really good understanding of why individuals develop severe symptoms and others don't. Because right now we can tell at a population level who's at risk. So we know that there's the elderly, we know if you have a pre-existing health condition, possibly if you have a higher BMI, they're looking into racial or ethnic issues that seem to be possible. But we don't know you as an individual, being a healthy 25-year-old, are you going to die of this? Or are you going to be in ICU? We don't know that yet. We don't know about what it is about the immune response. If we can get there, and studies are ongoing, including in Edinburgh and Oxford, then actually the countries that waited can then plan their strategies accordingly. So I think, just to say that I think this kind of idea of like lockdown or no lockdown is just kind of missing, that actually there's probably a better way through this in the short term, which is actually just kind of aggressively going after the virus itself instead of just locking down all of society.
Right. Thank you. That's so helpful, and also very sobering what you're sharing. We have a number of questions that are sort of related. Again, we have from Professor Chan from the International Center for Genetic Engineering and Biotechnology in New Delhi, and then also from, let me just find the person, from Mayur Patel. We have a question about countries in the global south where the potential for testing is so much, the capacity for testing has been lower. So for instance, Mayur Patel writes, if you take somewhere like my home in Zimbabwe, we've been under lockdown for 3 weeks and only tested less than 700 people. What are your thoughts on how we scale testing in less developed countries, and what are the merits of lockdown when you're not ramping up testing? This relates to your previous answer, but I want to ask you to focus specifically on under-resourced countries in the global south.
Yeah, and to say, Mayur, thank you for your question. Mayur and I worked together in Oxford
for
a number of years, so I'm delighted to see your name and that you're thinking and working on these issues too. I mean, I really struggle getting my head around what could happen in developing countries. I think when we first heard of this virus in January, my mind went to actually Haiti, because I had a postdoc who had been working there for 2 years on infectious disease control. And they were struggling at the time to get a handle on cholera, and hearing about all the challenges. And I really worry with this virus that even if a vaccine comes along, it'll be too late, because a vaccine is 1.5 years away. And we're now going from I remember yesterday that we had a cluster of cases in Wuhan, and we're now 2 million. So what can countries do? I think lockdowns may not be appropriate for all parts of the country. It might be you need to do that in big cities, but rural areas, I mean, I never thought I would be in this position talking about border controls, but I think the imperative is to keep numbers low. I think that's the only way to manage this. And testing is a real challenge. The WHO is trying with testing kits and getting out. And I think at least in countries like Zimbabwe and in, again, Senegal, Sierra Leone, you don't need to make the case for testing like we have had to do in the US and the UK. I think people just assume they know it's important. And so at least you're starting from that point and you can hit the ground running. But resources are going to be an issue. I think the key institution that will become important is the World Bank. In supporting countries, I think WHO doesn't have the resources to be able to actually help countries on the ground. They can advise, and that's what they're advising, right, to scale testing. But they're going to have to need a major influx of resources, and that has to come from an international institution, because the traditional bilateral donors are right now not paying attention to those countries. And this is going to be the next tragedy, because we basically seen this moving time, it's almost like being in a time machine. You have East Asia, and we were watching it and we were thinking that's so far away. And then Italy was hit, and the UK, and you have Europe and North America now, which are kind of aflame. And then at a certain point, we will get a handle on this. The question is how long it takes. Some countries have. Look at, Denmark and Norway. They're in pretty good, Ireland even. I mean, no one has a perfect solution, but they feel, they're comfortable. Germany as well. They still have a lot of spare ICU capacity, majorly ramping up their testing. And then this is going to shift. And the next wave of this is going to be in in sub-Saharan Africa, Latin America, South Asia. And I really, really worry because I think, one, will we even know about COVID deaths? Because you have to actually test to know if it's a COVID death. And the second thing is actually how many people are going to die because of delayed vaccination campaigns, you know, kids not getting vaccinated against measles. If you're in lockdown, can you get clean water? So I think the imperative is to kind of just keep your numbers low and try to, if that means border control for preventing importation of cases, which has been largely the route in, then that's a short-term price I think that's worth paying, which again, I never thought I would say. We always wanted open borders, interconnected world, but right now, and it is a very kind of once in a lifetime kind of situation.
Yeah, yeah. Well, you mentioned the differential responses from various European countries. And so I have to ask this question from my Scottish Rhodes House colleague, David Mungle, who asked, has Scotland handled the pandemic better or worse than England? And do you think Scotland could come out of lockdown earlier than England? And would they?
Yeah, so the tricky thing is that Scotland is not independent as much as many people here would like that to be the case, and is reliant on England and the other nations. They call it like the four-nation approach here for economic reasons. And so it's not like Scotland can just decide we want to do something completely different and walk away, because they're still relying, even for example, on the stimulus packages for that money that's coming out of London. So that makes it obviously very tricky. The other thing is there's worry about, even within Scotland, imagine if we raised our lockdown, because we only had like yesterday 150 cases, right? So it's a pretty, and some, you know, the islands of Scotland had like 2 cases, some have had none, right? So this is probably the comparator for theirs, like the Faroe Islands, rather than actually England in terms of the population density, the number of cases. What they don't want to have, and they're already seeing, is kind of a fleeing of people from densely populated areas into remote, like into the Highlands, into Isle of Skye. And so it's been a very considered approach. Like, could schools be a way? So you open up schools in those areas because people can't easily like take up their kids from there and move them there. But I think there's already been a lot of movement of people into rural areas from urban areas. And there's where you're kind of accentuating that if there's different geographical policies. Could Scotland have managed this better on their own? I mean, who knows? I would like to say hopefully we wouldn't have seen the deaths as high as they were. I think what we've seen is smaller countries have just found it easier to deal with. And I think it has to do not with the size of your population, but the decentralized response, that actually you can respond appropriately for your population. Where I think right now the problem in the UK is like it's a one size fit all. We don't have even the benefit of the United States system where you have states, right, who can differentiate between New York and Oklahoma and Michigan. Like, so you have a federal system. We don't have that here. So in a sense, when a policy is for lockdown, that means the smallest island and people in the borders and someone sitting, you know, on the Isle of Skye is in lockdown, whether that's necessarily appropriate. And I think particularly painful for those communities was giving up contact tracing, because if you had 3 cases and you traced those contacts, you probably could have pretty much contained it in that community. Where I think in London, obviously that's much more difficult. So yeah, so those are the considerations being discussed. I should disclose I'm on the Scottish kind of government advisory group that was set up just a few weeks back to kind of consider these questions. And our job is basically to listen to the advice coming out of SAGE and out of the UK government in London, to digest that, to analyze it, how it relates to Scotland, and then to feed back our advice back to SAGE down south. And so that's the way we have Scottish government sitting on our panel. And there are things that we're trying to do different though. So for example, we are transparent. So if any of you are curious who sits on the Scottish government panel, all on the Scottish government website, just look up COVID advisory group. You can see all the people who are on it. We list our minutes a few days later. So you can see last Monday's minutes and exactly what we discussed. And actually it's pretty accurate. And we're just trying to actually kind of take the Scottish public with us. We're going to probably publish an exit strategy in the next couple of days of all the considerations, the things you're raising in terms of geographical spread, in terms of testing, the numbers we might need, the trade-offs, how do we build it? Because I guess at least it feels like it's better to take people with you, that this is not an easy solution. There's no silver bullet, but at least to build trust by saying we're going to be transparent and share our decision-making processes, and at least the evidence that we're looking at to see also as a listening exercise. Maybe we're not thinking of something and someone in a care home or someone who's a frontline health worker can tell us, because we have to be listening to the people on the front line. Otherwise, we're making bad policies.
Right. That's great. So important, that commitment to transparency. You've talked about secondary infection, but we have a question from Alexander Straub about the experience of those who are basically asymptomatic, the 80% who are asymptomatic, that there have been, and I guess Alexander's asking whether you've seen any evidence of this, but reports of the virus attacking the T cell like HIV. So is it possible that this virus will attack the body subsequently in non-symptomatic cases? Have you seen any evidence of that?
I haven't seen any evidence of this, but what I think this points to is how much we don't know about the long-term implications of having this virus. And so I think this is why I'm extremely nervous. I mean, I've even heard, young people saying like, oh, I'm just going to expose myself, get the virus, then it's over with and I can get back to work. And that's obviously attractive, especially if you're relying on, you're in the gig economy and you have student debt and you're like, I'm young, I can get this. There's a lot we don't know. We're seeing out of Italy, all kinds of, neurological conditions a few weeks later. We're seeing that it affects the heart for people who have never had, heart conditions in the past. So I think it just points to like how much we don't know and how we should not assume that we know more than we know. I mean, I think when you listen to people speaking about this, whether it's on the news, be clear, are they saying what we definitely know? Are they saying what they think they know based on like their expertise? Or do they just not know? Because I think right now we have a lot of kind of conjecture being, thrown about. And actually, we just need to say at a certain point, we don't know. And we don't know the long-term implications of this virus. It's new. So it's better, I think, to not expose your populations to something we actually don't know enough about.
Right, right. So we, and that kind of relates to, this question about accountability. And you've mentioned, sort of the challenges around the blame game and accountability. We have a question from Poloko Leo Solela. Poloko, apologies if I'm mangling the pronunciation of your name. But you've asked, from a global perspective, what are the different levels of accountability for the pandemic? Is there any financial or legal recourse for countries?
So, unfortunately, not really. So the WHO is probably the closest we get to in terms of international laws, their international health regulations. So this govern that actually states are mandated to declare if they have a novel pathogen. So this is what China did 31st of December. They notified the country office in China that there was a new outbreak. And then WHO then shares that information with other member states. And this was set up after, we've had these for many, many years. I think from 1851, we had our first international sanitary conference. But this was, the revised ones were set up post-SARS to avoid countries hiding. But the problem is that if countries do hide the outbreaks, and now, China is now getting blamed quite heavily of, did they know about this since November? Human-to-human transmission. I think generally those of us working in global health were pretty sure this was the case in early January, but it wasn't confirmed until basically near the end of January. So there's obviously going to be investigations gone into according to like, was WHO fast enough at the start? And, should China have declared earlier? And is there any legal recourse for countries? I'm sure, Donald Trump would love to sue the Chinese if he could for this. But not really. We've seen this in the past with Ebola, with Zika virus, that actually WHO can advise and they can support and they can create norms around good behavior and norms around what's accepted. And, but at the end of the day, countries can do what they want. They can't really be punished if they don't play along to the rules. And same for financial recourse. I think right now, instead of recourse, I would call it actually just aid, the World Bank, hopefully. If you're interested in looking at something quite, again, you have some time and you want to dig into something. We were working for a few years on pandemic bonds. So these were set up by Jim Kim at the World Bank to basically have a payout mechanism for countries in the course of an outbreak, that they would actually sell these bonds and then actually they'd pay out if there was an outbreak. Incidents that we studied these for a while and then left them. You won't believe it, but they haven't paid out. And even if they do pay out. I haven't looked today. Maybe they paid out today, but from earlier this week, they hadn't paid out. And if they do pay out, it's 130 million. Whereas actually the World Bank's already committed like billions, and you're seeing in the UK and the US, we're spending hundreds of billions. Like 120 million is a drop in the bucket. So I've stopped focusing on them because I see them as a distraction. But I think if you want to learn, I guess, about new instruments that were created and actually did they work as intended, that's a really interesting case study to look into.
Wow, very interesting, very interesting. So also thinking about kind of the impact of the pandemic on other elements of our systems, health and political systems. We have a question from Shruti Iyer. What do you think the long-term impact of the response to COVID-19 will be on the rest of the healthcare system, particularly for diseases such as TB in India?
I think generally across, I mean, I'm trying to think of exceptions, but I can't bring to mind, this will be very destructive on many other disease agendas, because you're already seeing, I can't speak to TB exactly in India right now, but you're seeing with like polio eradication, that's been put on hold for 6 months. You're seeing, resources are just being redirected. The outbreaks become like black holes. And that's going to be true in poor countries with disrupted vaccination schedules, with different vertical programs like for TB and for HIV basically being redirected, because these are the structures governments have. They're just going to redirect them towards COVID response. And I think even in high-income countries, we're seeing delayed care. So, for example, cancer treatments are currently being delayed. Dermatology is basically shut down. So if you have a skin condition, you've got to wait, and who knows the implications. I know there's a lot of worry about delayed pediatric care. So for kids that actually, because there's this, I guess, such a fear of going into hospital, that actually parents are not even coming in when their kids are quite ill and need care, and delaying it. And could that explain why we're seeing a rise in non-COVID deaths already? And what will this mean? So I guess, I see, in the start, I've seen COVID almost like a fire, which is how you see outbreaks, which is like the faster that you can put out that fire, you can save as much as you can of the rest of the forest. Whereas the longer you let it burn, it's just going to burn everything. And as the numbers increase, and the terrible position governments are going to be put in is choosing between COVID deaths and non-COVID deaths, and having to prioritize whose lives. And it's a horrible position to be in. And so I think as much as possible, if we can keep numbers low, then those decisions don't need to become as acute and made. But yeah, it's not going to be good for any kind of agenda. Maybe in this new world, when we come out of this in a few years, they'll be thinking about how do we actually prioritize health and healthcare workers and value essential workforce, and think about preparations. And actually I imagine that if we didn't stockpile gowns and, things like this because they were too costly 2 years ago, that looks silly. Right now, like, cost is out the window. So also interesting, usually in policy, guidance or situations, you're always using cost benefit. How much does it cost? Is it cost effectiveness? Is it micronutrient supplementation? Or is it deworming? Or is it, and here I'm like, there's no cost component because anything is cheaper than what we're doing. So it's quite a strange place to be in, that basically if lockdown is the instrument we have, anything other than that is going to be cheaper.
Yeah, quite amazing. We have somebody's raised their hand, Alexei Youssef, who is a scholar from Syria. Alexei.
Thank you, Devi and Elizabeth. It's been a very interesting webinar so far. So Devi, I'm really interested in this question. So a lot of countries around the world have implemented very early lockdown measures. So for example, countries in Central and Eastern Europe, so Slovakia or Ukraine, and also some countries in the Middle East like Syria. So I'm wondering, because these countries have implemented such early measures, the number of cases there are low, although I recognize that it can be low because of the limited testing capacity. But I was wondering your thoughts on, is there a risk of secondary outbreaks, or those countries becoming the epicenter of the outbreak after they lift the lockdown measures and relax basically regulation on incoming travel?
Yeah, and I have to say, actually, I think that was quite a wise move we're seeing to lock down early, because then you can keep your number of cases low, and that way you're dealing with, dozens of cases instead of hundreds of thousands. But I think all countries now are facing, there's I'm going to outline kind of 3 short-term paths and 4 long-term paths, right, of where this is all going probably for all countries. So the 3 short-term paths are either you just let it go and you see who makes it out on the other end, right? So people die, they die, but you don't just do anything else. We've seen that's politically unpalatable. I mean, publics won't accept it, regardless of the moral question. The second one is lockdown and release cycles, which means, yes, you're going to have in every population a lot of people who are still susceptible, which means as soon as you lift these lockdowns, you're going to see a rising number of cases, because unless you know and you break chains of transmission, the virus is going to keep transmitting. So of course you're going to have a second wave and a third wave as long as the virus continues to spread, and then you keep trying to suppress it as you can. The third way is kind of the test, trace, isolate, which is just trying to like actually get a handle on who has it, and ultimately, hopefully working to some situation where your numbers are like, you know, you're getting a handful of cases every day. Again, like a small fire, and you can just keep putting it out through like quarantining people, or hundreds of cases even in the context of larger populations. But where is this all going in terms of like, what are the future scenarios? You know, for me, there's basically, you know, 3 ways this can end. Either we get a vaccine and everyone is just doing short-term strategies, one of those 3 to get to the vaccine. So we're all just in holding, almost like a plane in flight, you know, you're just holding and you're trying to save lives until that point we get a vaccine in the next year to year and a half. In Oxford, I know Professor Sarah Gilbert seems, you know, quite optimistic that she will have something working by the fall. That will be transformative, especially if we can get the manufacturing up and we can actually distribute it. So that would mean the countries that did early lockdown were quite wise, because that meant they just kind of bought time in a way and protected as many lives as possible. The second way this can go is we don't ever get a vaccine, because, you know, we don't have a vaccine against any other coronaviruses, and we don't have one against HIV or malaria or dengue. And so we can't, it's not like we make a vaccine for every, you know, virus that we have or every parasite. And so there we're hoping for some kind of antiviral therapy, which means some kind of treatment. Ideally, it'd be some kind of prophylactic treatment, something you could give to people, you know, early on in their exposure to, you know, to the SARS-CoV-2, which meant that they would actually be not developing severe symptoms, or to people early on, like if we have testing in place, once they know they have it, to quickly take it to descend into critical or severe. That would be transformative as well, because then this would become a mild infection and you could just take a treatment. And there are many, again, you know, hundreds of drug trials taking place now to find something. So that would be another way. So you're in holding until this comes out. The third path would be that actually we don't get an antiviral, we don't get a vaccine, and we hope for immunity to build over time. This to me would be like a version of kind of like survival of the fittest, which is like all of us get it and we just see kind of who makes it through to the other side. And that'll be obviously context by country based on their healthcare capacity. So some epidemiologists say in 3 years, the only difference between countries' death rates will be on their healthcare capacity and how many people they could save. Then the fourth, which is like worst case, but we always got to put all scenarios, is that actually no immunity ever develops and that populations keep getting hit by this, which means, you know, you have it when you're 20, then you get it again when you're 22, then when you're 24, then when you're 26, and hopefully you get a less severe version, but maybe you have immune enhancement and you get a much worse version of it, which means at some point, countries which have the capacity are going to try to eliminate this. New Zealand's attempting it. I think Australia at some point might, if they're able to, given some parts of the country have such few cases, you know, small islands are doing it. You basically say, we cannot live with this virus. So we are going to eliminate it and put in border control, and you'll basically create a world where maybe like between Australia and New Zealand, you have free travel, but then anywhere else you need to have a 2 to 3 week quarantine. That's another route we could go to. It seems like people don't want to talk about elimination or eradication, and I get that because it's very difficult. We've only done it for smallpox. I think eradication is probably out of the question now. We don't have a vaccine, and it's in over 200, you know, countries and territories in the world. But I think we might see countries who are able to doing national eliminations. We need to keep that scenario on the table. So that's basically the 4 ways this could play out, because lockdowns and release and test, trace, isolate, they're just buying you time in the short term. They're not feasible, I think, for decades unless we actually get a better scientific breakthrough. Science is going to be the answer here. Hopefully that answers your question.
Yeah, thank you very much.
I keep forgetting to unmute myself, so sorry. Thank you, Alexi. So Devi, and this was a question actually from several people, is what has surprised you about this particular pandemic, as somebody who, you know, has studied Ebola, has studied SARS and MERS. What have been the biggest surprises? And a quick follow-up question from David Mungle is, how are you personally coping? You must be working 24/7. How are you taking care of yourself as you try to respond to this?
Thanks, great question. So I guess on what surprised me, I think it's that people find it surprising that this has happened. I mean, we've been extraordinarily lucky not to have something like this occur. I mean, just imagine a virus like this with, a higher fatality rate. This has been kind of a big worry for the CDC, for the WHO, for global health experts. And so when you hear, senior political leaders or others say, oh, we could have never seen this coming, that surprises me, because I'm like, well, actually, if you read like a WHO report from September, like chapter 3 is respiratory pathogen that, travels around the world. And so I guess tied to that, just how slow different the reaction has been, like speed is of the essence. So usually policy is made over days and over weeks, and we try to get it right? You say, okay, it's better we spend 3 weeks getting this policy right than rush it. But I think in outbreak situations, it's a trade-off, because the more time you trying to get something perfect, or trying to get all the evidence, or trying to get an RCT done, or kind of the standards of evidence we have, you waste valuable time that actually you could be responding, because the virus keeps spreading. So whether it's a weekend, whether you're still discussing it for 3 days, and that's how we work generally, we think in terms of weeks as being fast. I mean, in days this is moving. And I think that will be a lesson. I think this is not going to be the last virus that we see. It seems these events seem to be increasing in frequency, that actually people won't be surprised. And so we'll have the necessary preparations in place. But second, they won't be slow, because, we've seen the early movers are in a much better position. And that's, I think, a lot of what South Korea learned through its MERS experience is going to be what many other countries learn, especially high income countries. And we see how they respond to the next one. How I'm coping? Yeah, I mean, to be fair, it's not, I mean, I'm personally, I'm doing quite fine. I feel like right now quite focused on the work I'm doing. And I think it's incredibly important that we get the evidence to, decision makers as fast as possible. And so that they're making, because, there's going to be decisions made about exiting lockdown, whether we like it or not, right? Like there's going to be a decision made. And so it's better we do what we can to put the evidence into those hands and to bring, the media and the public with us on those decisions, rather than just letting them be made in the absence of kind of any kind of input. So I feel like quite focused in my work right now, and thinking like, actually, this is, I can take a holiday at the end of this. To be honest, though, psychologically, I've struggled, because obviously when this all started in January, we all hoped it would be like SARS or MERS and it'd burn itself out, right? In early January, you've got to prepare for the worst. That's why we always have to have the worst case on the table. But you kind of hope it'll be like, maybe it'll be so infectious. The thing about SARS and MERS is, if your fatality rate is too high, then actually you can't transmit as effectively. So there's a delicate balance between how dangerous the virus is and how easily it spreads, right? So this has found a very tricky balance. This virus has managed to navigate both compared to other bugs we've seen. And so I think realizing over the weeks, and I've probably been quite anxious since January, and increasing so, that people don't get it until it's at their front door. So even in, I was talking to friends in early February, telling them I'm like, you're really worried what's happening out in East Asia. And they were like, oh, you're always so panicking. And actually people don't get it till actually they go into a hospital and they say, wow, there are a lot of patients dying, or they know someone who's been affected by COVID, or they understand this is a big problem for all countries of the world. How do we go forward? So I think that's been kind of a challenge in terms of, this is going to be with us for a long time. Is it going to be like in the past where we just get on a plane and we get off it and we see our family and we see our friends, and then we go back on the plane and we fly somewhere else, and we go to a big concert, and then we go to a sporting match? Probably not. I think that's probably not going to change until we get a better solution out. This is going to be with us for years until we find a scientific solution, or immunity builds somehow, or something. There's no easy solution unless this miraculously disappears, or mutates in some way to be a kind of a milder coronavirus. We have seen no signs of that happening yet. So I think probably everyone's faced with this, where I'm thinking, what is life going to look like for the next year, for the next 2 years? What does it mean not seeing close family? What does it also mean if this is going to spread to everyone, for all the people I know who are vulnerable? people I know who have asthma, who have heart disease, who are elderly, who would have long and fulfilling lives. What does it mean for the health workers who are going into work and are very anxious? If you look back on my Twitter feed, I posted in early March letters I was getting from former students in Oxford and in Edinburgh, medical students who were put onto COVID wards with no protection and felt torn between their duty to patients and their duty to themselves and their families, and they're worried about becoming a transmitter of the infection to others. And finally, and I guess this was raised by Mayur, like, what does this mean for poor countries and for governments? I mean, you're already having kids dying of childhood pneumonia, which is preventable by antibiotics and oxygen. And oxygen was seen as being kind of out of reach for many places. And you have kids dying of diarrhea because they can't get clean water. We have, still outbreaks of vaccine preventable diseases. So to put this on top of it, when you know that agenda is so fragile and that the gains made in child health, we have seen child health improve. Are we going to see reversals in those? And there's no easy answers. Like, I wish I could have like an easy answer to tell one of the governments, but this is going to be a slog and it's going to be quite painful from a human life perspective. So I struggle with that. I mean, it's a long answer for how I'm coping, but I'm saying it's not easy because there's no easy answers. And so all we can do is kind of stay focused, take it day by day, and try to look ahead and say, we all can just do what we can to help our communities and from the perspectives that, we're in, try to work towards, I guess, a better world.
Thank you so much, Devi. And I just want to, we are out of time. But I just want to say to Professor Devi Sridhar, what an amazing conversation. We really appreciate your sharing your expertise. We really appreciate your leadership and your resilience. And as you said, this admits of no easy solutions. It will take all of us. It will certainly take scientists around the world, but also policymakers and public intellectuals to try to come together to navigate this. But we really appreciate your being with us this morning and sharing your expertise. Really appreciate everybody who participated and all your wonderful questions. Apologies to those whose questions I wasn't able to pose, but there were so many questions. We got to as many as we could. And for all of you, thank you for participating. We will look forward to your feedback and your ideas for further digital events. We do want to work in all the ways we can as the Rhodes community to try to share information and insights and be a catalyst and connector across our lifelong fellowship. Devi, thank you so much for being such an inspiring leader in this very challenging time. And everybody, thank you for joining us. Have a great
Thank you, everyone. Bye.
Stay healthy, stay well.